All right. Thank you all for joining us today. We're really excited to have our SSAT Grand Rounds format with a presentation from Dr. Tiffany Son from the Banner program. She's talking about "We are not what you eat," and I love that. The moderator for today is Dr. Mattar, who's a dear friend and colleague, is a professor and chief of bariatric surgery at the Baylor College of Medicine in Houston, just down the road from me. I'm so glad that we were able to get into Texas. So without further ado, Summer, let me hand over to you, and please take over. This is meant to be interactive, so we want you to jump in and ask questions, and we really want to try to get a good idea of some of the nuances around this. We also want this to be a little bit more postgraduate, and so we do want to hear your sort of the nuances from your practice, Dr. Mattar, which is, a really high-end bariatric practice, and where we stand with some of these controversies. Thank you so much. Without further ado, Dr. Mattar.
Thank you very much to the SSAT and to you, Dr. Jayaraja, for inviting me. And I believe we might have Dr. Pokdameni with us. I'm not sure. I thought I saw him. And there you are. Hi, David. Would you like to introduce Dr. Son? Oh, you're muted.
I said it will be my pleasure, Sam.
Thank you.
So Dr. Son started with us, obviously, this year. She comes from University of Arizona. And she's already, I have to say, a big star in our program from the fact that she is excelling in terms of her achievements in the operating room. And she's extended our program to our sister facility at Banner University, and she's integrating a more academic flair to our program. So she's not just participating as a fellow, but she's also extending the reach of our program. So that's Dr. Son.
Thank you. Thank you very much. And it's good to see you again, David. And two interesting facts that I learned today about Dr. Son is that she actually, although she was received most of her higher education in Arizona, she did travel to Cape Town, where she did some open appendectomies because the patients there were so far advanced in their diseases, and then stopped in Bali on the way home, where she did some C-sections. So we have a well-rounded young surgeon with us here. But without further ado, let's hear your presentation, Dr. Son. And by the way, for the listeners who are participating, if you have any questions, please put them in the chat box. We are monitoring it, and we will then ask them at the end of her presentation. Go ahead.
Well, thank you, everyone, both Dr. Mattar and Dr. Pokdameni, and thanks for having me as one of the speakers. I'm excited today to bring you a topic that was sort of intriguing to me and made me curious. So my topic is "You're Not What You Eat: Gene-Targeted Therapy Aiding in the Algorithm of Medical and Surgical Weight Loss." I'm here at Banner Gateway in Gilbert, Arizona. I have no disclosures. So the topic of "you are what you eat" for me is a big deal because I'm a big foodie, and that phrase sometimes gets you. But there are a wide range of weight loss programs. I think there's as many weight loss programs and nuances to it, as many as the new kitchen gadget in your kitchen, from the NutriBullet to keto diet. So it's a big topic, and it's a lot to cover in an hour, and I want to this be a little bit of a tip of the iceberg slash maybe gets you inquisitive about the topic. Bariatric surgery in itself has shown through multiple studies that long-term treatment for morbid obesity and this disease has been more effective than all the other diets and exercises that are going on. And ultimately, 20% of patients do fail to achieve or maintain their weight loss or have reoccurrence of their obesity disease. So right away, you are met with a challenge in obesity of trying to figure out which treatment type is more effective for different people. And I know we have all different ranges of my audience right here, and if they want to chime in their experiences or different studies that I don't have on this presentation, then I'm more than happy to entertain them as well. Right now, there's no profile to predict which surgery or which route a patient takes that will be the most efficient and more effective way. And I include this magic 8-ball. I don't know if people know what that is, but if you ask a question to it, it gives you this silly little answer. And one of the answers I think that we can look at to look for our answer would be in genetics, and not only the phenotype, but also the genotype of obesity. So I'm going to go through a couple of these studies that are out there. There's certainly a lot more. So BMI has been seen to have a correlation with the melanocortin-4 receptor, as well as fat obesity associated, and there are a lot of acronyms, but NPFFR2, and there has been a correlation with BMI. Not only is there a correlation seen in adults, they're seen in the pediatric population. I know we learned in med school about the leptin-ghrelin tango and all of that, but the leptin receptor does seem to have an influence on obesity in infants, as well as protein kinase C. There was another meta-analysis that showed that BMI and the SNPs, so the in DNA in the East Asian population showed about 10 BMI associated loci that have a significance in predicting BMI. I want to say that as well as different processes in the DNA processing, one of them is DNA methylation. Earlier I alluded to the SNPs in the protein genome, and they have also been associated with the BMI, the methylation process in itself. There's also the CPG sites that show that these methylated regions do predict the disease. So while we're talking about the genomes, there was interestingly a twin-based study that showed that the serotonin transporter and promoters that were hypermethylated in white blood cells increased BMI, and waist circumference did correlate with that as well. Just in these two slides alone, I covered a lot about the genes, the proteins, the immunotherapy with the white blood cells. There's a lot that just that one word obesity, I think we undermine it a lot, but it's a whole process in its own. And I think with further research in each little process, I shouldn't say little, I just undermined it myself, is that if we can target these genes, we'll have a better way to produce individualized surgical and medical treatments. And I know I say surgical, well, you just said all these genes, what does it have to do with surgery? Well, bariatric surgery has proven to shown long-term benefits and is the most effective of them. And we all say, oh, heal with steel, but how? Like, how can we do that in bariatric surgery? And we've shown that over time we can, but I think our surgical options are going to be more limited than our genetic treatments. And that's where I want to bring this concept up and this idea that gene-targeted therapy does help surgery, and it helps to understand that which genes may be affected differently by which surgery that we offer patients, whether it's the sleeve or a Roux-en-Y gastric bypass or a duodenal switch. These genes are affected all differently by the surgeries that we choose, and we just simply are not aware of it yet. So there are a couple of studies. So there was a study of about 1,000 individuals who went Roux-en-Y gastric bypass surgery, and they looked at the obesity genes, in particular insulin-induced gene, MC4R, and PCSK1 genes that showed with poor weight loss outcomes after Roux-en-Y gastric bypass surgery. Another study showed that all the patients for up to 2 years before and after, and that patients who had the MC4R common allele would have a longer and achieve better weight loss. So it'd be interesting to know or see like which ones of our patients have had this gene, or did they have multiple surgeries in the past where they went from a sleeve to a gastric bypass, or how can we target our patients better? I think in the long run could be more cost effective by knowing this data. In the sleeve data, there wasn't as much genetic sleeve data, so I think it's definitely an opportunity for us in the bariatric community to gain more insight on this genetic factor. There was a study in 2016 that showed it was mainly comparing genetics versus the environmental influences. And it did show that it seems that families that live together or did not live together, whether it be either one, it seems like there is a genetic component that influenced laparoscopic sleeve gastrectomies more. But like I said earlier, there needs to be a little bit more data or research that we can do with this, and I think it'd make a good study. Another surgery that we often do in bariatrics are our BP diversions, and it showed that patients had a greater weight loss with the mutant leptin receptor gene, as opposed to patients that were found to have a wild type protein leptin. They also saw that there's a genetic variant in the glucagon-like peptide 1 receptor, and it did have an effect on clinical outcomes after BP diversion in the timeframes of 12 and 18 months. Like I said earlier, this talk was meant for me to be a platform so that people can start talking about their thoughts on how genetics fits into bariatric surgery. But I just went over a handful of studies that showed that bariatric surgery, depending on which type of surgery, may interact with even different types of genes. And I think that different types of bariatric surgery may be able to be targeted to our patients in order to have a better outcome and a better long-term outcome as well, if we were able to profile our patients. I think the future of bariatric surgery might not be in the surgery itself, but the additional components that come along bariatric surgery. And if you thought of it more of like neoadjuvant therapy before bariatric surgery, and even whether that be targeted immunotherapy with, or also endocrine therapy as well. And I think that's where the future of bariatric surgery will be. That's pretty much the underlying topic that I wanted to cover, but I wanted to open this up for other people to share their wisdom on this topic. Thank you.
Thank you very much, Dr. So, for a very nice distillation of a lot of the information that is out there that admittedly is still evolving, and also for confirming a lot of what we've anecdotally felt in our clinics when we see patients who've done well, meaning, you know, who've overcome their comorbidities and lost weight and maintained it. And then we operate on members of their family. It's almost expected that their family members are going to do well. So this helps a lot. I suppose, you know, and I'd like to also please solicit from everybody attending to ask questions. But while you're still gathering your questions, I'd like to ask Dr. So, I suppose, you know, one of the things that this information, having this information in our possession, is that theoretically we'll be able to match a patient with a particular operation. But I sometimes wonder about the opposite and how that can play into the hands of some stakeholders and use it against the patient, meaning, you know, that they would go to the patient and say, according to your genetic makeup or the variant that you have, we cannot, for example, agree that the sleeve operation that you want is the right one for you. You see what I'm saying here is, you know, it would be nice for us to be able to correlate or predict outcomes based on genetic variants. But you wonder if this could be used against the patient. It's a philosophical question. What are your thoughts about using genetic information in that way?
I mean, I would hope that genetic information like that wouldn't be utilized like that, but there is always that possibility when money is involved. I could see how two operations, somebody makes more money that way, and it could hinder the patient.
Yeah. Again, while we're waiting for questions, I have another question. And, you know, you've shown us how genetic variants may influence outcomes of bariatric surgery. But do you think also there might be a role in predicting how patients receiving medical pharmacotherapy for weight loss might also be affected by different genetic variants?
Oh, yeah.
As adjuvant therapy.
Oh, yeah. I think from a medical pharmacotherapy, I think there's more out there than I would almost compare it to like breast cancer therapy. I think we're far behind them, and I think there's like how they get Oncotype DX, or they get a score that says, oh, you would be optimal for this and this treatment. And I think bariatric surgery has that potential, and with more research and knowledge, I think we could get there, and I think that could be our future.
Yeah,
it's Rohan here. I just kind of wanted to jump in because one of the things that sort of struck me today is I saw a patient that actually I'd asked to come and see you, Samar, for weight loss surgery. One of the questions I thought
always beware.
one of the questions I thought about was, so as we think about weight loss surgery is there a downside to starting out with a sleeve? Because you can always then go to a switch or a bypass, right? So is there a downside with that being our go-to procedure? Again, not talking so much about the genetics here, but I was just wondering what you all thought as experts in this field as to whether that's like a good place to start, because you can always go back and do the bypass, or you could convert them to a switch.
So, this is a bit of a controversial topic, but by and large, we consider the sleeve a very versatile operation and a nice basic one that does lend itself to other operations. It doesn't burn bridges. You can convert from that to pretty much anything, really. You can do a bypass, you can do a duodenal switch, and so on. So as long as there isn't an absolute contraindication against a sleeve, then yes, your approach is correct. However, we really try to counsel the patient that they should ideally have only one operation. I mean, we try not to tell them, okay, unless it is a planned staged approach, and there are incidents when we do that. By and large, we want them to be their one operation, with the caveat that they might need a second operation. David, what do you think?
Yeah, I was going to ask and try to help out my fellow a little bit too, I actually agree very much with you, Samir, when you say that our objective is one operation, but I don't disagree in terms of using the sleeve as leverage if the patient will need a second operation. In addition to that, the fact that we are seeing, and I think that's what Dr. Son was trying to convey, the message that, basically from our standpoint, when we say our standpoint is our fellowship and our training, we try to implement a view on obesity that it's more complete, more holistic, where obesity is not only what you eat, by far, and it's really there is an implication not just from your predisposition in terms of genetics, but again, not using the genetics as the determinant factor in how you're going to treat that patient, but using the genetics as leverage again to possibly, like you mentioned, use medications as, like Dr. Son mentioned, like a neoadjuvant or adjuvant therapy. And understanding, and I think that's the most important thing, understanding that the surgery is not a finite process in the treatment of obesity, that surgery is just part of that treatment. And what we try to convey and bring to the patient is that this is an ongoing treatment where surgery, let's say chemotherapy in the sense of adjuvant therapy to the surgery, those are tools in our toolbox that we have to use, I think, in order to better address the problem that we have in terms of how we better treat obesity.
Exactly, thank you. Yeah.
I just want to mention something that might be a little controversial, is like, I think the sleeve is a very good procedure, but one thing that I don't think a lot of surgeons do is Omentopax, which is kind of reapproximation of, the basically severed attachment on one side and reattaching it. We know as a fact that the incisura tends to be where obstruction tends to occur. And we always say, oh, stay away from it, and we concentrate on bougie size. But if you look at the angle of the stomach after sleeve gastrectomy, sometimes that angle the stomach looks like an S rather, or a straight line. Sorry. So that being said, I think if we perform Omentopax at the upper section and the lower section, that can widen that incisura angle. There's literature coming out that basically say that that is a good thing, and that probably decreases the percentage of patients getting reflux and decreases the number of leaks. So I just want to mention that the fact that Omentopax, I think, is something that people should be doing, and I don't think a lot of people are.
Thank you, Dr. Chow. Yes, David.
Can I mention something on that? It is because I think Dr. Son can share also that experience with Omentopax with all of us. That we started to do that, and we don't do it on a regular basis on every single case, but like it was mentioned, when we see there is a possibility of some degree of cork in that angle, or there is deviation of that angle that we're satisfying seeing a smooth transition in that sleeve, we've been doing Omentopaxes. And one additional thing that I think it's important to understand in treating obesity is the surgery is an excellent and great tool, but the surgery is just a small portion of it. And we tend to explore a lot in terms of, I think the sleeve is better than the bypass, and the bypass is better than the duodenal switch, and this and that, and going back and forth. And, in my view, at least, and our view is, shouldn't we, and I think we're going in that direction, is exploring other venues and really seeing the surgery part as just really part of the therapy, and launching other venues like genetics, like immunotherapy, and other adjuvant therapies in treating obesity.
I agree completely, David. I don't think we're going to advance the field by comparing and one operation against the other. We have to extend our horizon, and this is why this talk about genetics is so timely and so important, and I'm sure this is going to be an expanding field of research. Dr. Chow, I have to tell you, after 10 years of doing sleeves, I'm confident. I can categorically say that no two stomachs, and I'm sure you'll agree, are the same. Every stomach looks different, and some are straight, some are J-shaped, some are, big and boggy. And what I'm trying to say, and what I teach my learners, is that you have to apply different technical nuances for each stomach. I don't believe there is a blueprint. Sure, there are wide technical rules that you have to follow, but then each stomach needs a little bit of address. When you look at it at the end, after you remove the bougie, you look at the sleeve and see what it looks like, and try and correct it if needed. I have to tell you, I've had the sad occasion of having to go back into a patient's abdomen, sometimes 2 days, 3 days after surgery. And I don't typically do an omentopexy, but nature does it. If you were to go back in after 2 or 3 days, only 2 days after surgery, you'll find that the omentum has already encroached and covered the entire staple line, as I'm sure you'd have seen. And so I personally, I'm not in favor. I'm not strongly in favor of omentopexy. I'd like to
topic, but I'm in favor of it. I know there's literature coming out, especially like this last year it came out. There was 2 other papers that came out. One said it made no difference, and another one said it made a difference. So if you look at the literature, probably over this one topic, there's about 5 or 6 papers. One says it's good, one says it's bad, and then 4 paper says it's good. But I think one thing that most of the papers don't have is what are the angulation of the incisura, right? When they say omentopexy, that could mean anything. You could be pexing to the colon, right? If you pexy the omentum directly to the incisura, then you're going to make even a sharper angulation. So I think when you have, I think most of the time, I think you're right. The stomach looks fine and it's okay. But if the patient's stomach looks kind of straight or start to bow on the other side, yes, scar tissue could form, but it's still going to form with the stomach bowing to the opposite side, and the stomach is still kind of going to look like a lightning bolt or a Z. And if you just look at the stomach when you first came in, all I'm saying is maybe we should try to reapproximate the stomach and have all this attachment that was previously there, and just kind of reestablishing it. It cannot be bad, right? I mean, this is how the stomach was when you came in. It was established on both sides. There was pexing, there was adhesions, there was scar tissue, there was something holding it.
Thank you, Dr. Chow. just to take us back to the main topic at hand, Dr. Son, do you think that there's a, when I talk to patients in lay terms, I explain to them that our genes in general tend to protect us from weight loss, right? They tend to protect us from famine and starvation in times of stress, and basically now, because of the abundant food and the metabolism changing of our patients, we are working against a lot of the genetic makeup that our patients come with, this protective makeup. So I wonder if these studies are identifying these so-called genes that promote weight loss, that promote so-called success after bariatric surgery. Are they actually genes that might have hindered patients in older times?
That's a great question and an interesting topic. I'm sure there are studies, especially one of the things that brings into mind, especially being from Arizona, is our Native American population. Obesity is highly prevalent in that population. I'm not sure if there's a pinpointed gene that they found that, but I'm sure if I looked it up, I could find something that they found in our Native American or indigenous population that was supposed to help them, but like you said, now is hurting them.
And again, any questions from the audience, please?
So, Samar, I'm always full of questions. So let me just ask you, because I'm old enough that I remember the early days of gastric bypass, and there was a great interest in sweet eaters versus non-sweet eaters. So can you kind of, David, Samar, Dr. Chow, can you help us non-bariatric surgeons in where do we stand with this? I mean, is this a different genetic phenotype that's being expressed in some ways? Can you suck a McDonald's milkshake through a sleeve pretty easily, whereas hopefully the dumping will help you with the bypass? I mean, where do we stand with this? Because this was a huge deal in the early days of gastric bypass.
David?
Well, this was not just with the gastric bypass, but also especially with the band. When we did a lot of the bands, when band was coming out, this was a big deal in terms of sweet eaters versus non-sweet eaters. And in reality, what at least we tell our patients at this point is that, again, I'm going to reiterate the same topic where surgery is just part of it. And what happens is you do have, in certain families, in certain people, they do have a predisposition in terms of accumulating fat. And that's a reality. And what they need to do is to address that fact by understanding that the surgery is actually not providing them with tools in order to avoid being sweet eaters or in trying to avoid any kind of special diet per se. But in reality, what the surgery is providing is changing in the internal environment, in their milieu, in their hormonal response when we do the procedure, either a sleeve or bypass or a duodenal switch. We are in the infancy, I think, on what exactly hormones are changing when we're doing things. We know for sure there, this is well described, the ghrelin factor and substance P, PYY, and GLP-1. But, we're finding out that, just from the fat cell itself, you have more than 40 tiny peptides that are being produced or released or differently produced and released when we do surgery, either sleeve bypass or duodenal switch. So it's conveying that information to the patient at this point that I think it's key for them to understand that if they don't change their nutrition in terms of not just sweet eaters versus non-sweet eaters, that they have to adapt in terms of changing physical activity, in terms of changing their lifestyle, in terms of changing their diet, that it's really going to make a huge difference. And I'm just going to mention something. Recently, as 5 years ago, NIH did a randomized control trial on patients who were submitted to low carb diet, low fat diet, and low calorie diet. And there was no major difference in terms of the diets. There was a slightly more weight loss with the low fat diet, but there was no real difference if you're really cutting one versus the other. Ultimately, what you're doing is cutting calories, and making the patient do that by cutting carbohydrates or by cutting fat. That's one way of doing, and someone will adapt maybe a little bit better to cutting the carbs or cutting the fat, or just plain lowering their calories. But ultimately, it's lowering the calories that's going to ultimately makes a difference in terms of how to change your nutrition. And associated to what we said before, which is the hormonal change led by the surgery.
Thank you, David. And yeah, Rohan, you know, the sweet eater versus non-sweet eater thing was very prevalent back in the days of the band. But these operations, such as the bypass, the sleeve, they affect the hormonal milieu changes, and it affects patients' preferences. So a lot of them move away from sweet foods. I see Dr. Rosemurgy has a question, please.
Alex, you got to unmute. If you're on your phone, do *6 if you don't mind. Because we can't unmute you from here.
Alex?
Or hit your space button, that'll work too. Okay, we'll try to get him unmuted. Alex? Okay.
I think he's lowered his hand, so maybe he doesn't have a question at this time. But if he does, we'll be happy to have it. What else?
Can I just agree with Dr. Mattar in the sense that about the genes? I totally agree with him. When I consult with a patient, I tell them actually that they have good genes, that they're not have poor genes. A lot of people talk about they have genes that are no good and that's why they're obese. I say, actually, you have great genes. These are genes that would help you in survival if you were on like Naked and Afraid, right? And you have to like egg out existence, walk 80 miles to kill a porcupine. But the simple fact is we don't live in that type of culture anymore, right? We can go to Wawa, get a shake. We're not in danger of being eaten by a saber-toothed cat. We don't have to run at breakneck paces anymore. So all these genes that were great for survival is no longer as useful in a mechanized society. And I think, as he mentioned, one thing we have to be aware of is if we come out with these blockers or stimulators, are we in fact kind of doing things that perhaps would be detrimental for future human being survival? That's another question to ask. If everyone's ever seen the film, and like policing too, like ever seen the film Gattaca? I'm sure a lot of people seen it, you know, where they control everyone's life based on their genes, right? What you have, what you don't have. And then it becomes a new form of like racism, right? Through genes, what you have and what you're allowed to do, what you're not allowed to do. I think as David said, I think we should continuously emphasize that it's a change of the person, maybe spiritually or maybe their culture that needs to help adapt and help the operation. As I mentioned to patients sometimes, I said, listen, it's like you're going off to fight a bear. You got your nails, you got a rock, you know, good luck, you're probably gonna die. But what we do in surgery is we give you a machete, you know, we give you a knife. You still have to go and fight. You still have to do what you need to do. But we're just giving you slightly better tools to get the job done.
Thank you, Dr. Chow. Dr. Son, one of the nice things that I liked about your presentation is that it reinforces a lot of the information we anecdotally give patients, such as especially those who struggle with weight recurrence after surgery. You know, they feel very disappointed. They feel that this is their mistake. They feel that they've done something wrong. Admittedly, some of them think we did something wrong and there's something wrong with the surgery. But it's nice to know that there is a genetic background that can reinforce what we tell patients, in that primarily this is not your fault. This is the disease that's just, we need to recognize that it's a chronic disease, that it's a recurrent disease. And this is why follow-up and lifelong support is so important. My question to you, though, is, and I don't know if across your research, have you come across the fact that genetic variants might be cumulative? In other words, if you have 2 or 3 variants in one individual, is that worse, so to speak, than someone who has only 1 variant?
That's a good question. I didn't come across any of that, but I'm sure it's hard to study one gene, let alone the cross communication between 2 and 3. But I think it's something that needs to be looked into. Like, are these additive? Are these a summation, or how did that play a role? I don't know. I didn't come across.
Or they negate each other?
I don't know. Dr. Pokdameni, do you know any?
No, I don't know any particular study, but I have to say that I think we're in the infancy of trying to do this target therapy, and but it's in an infancy that it's going to grow, and it's going to go rapidly. I think it's what the future is in terms of, I'm not going to say bariatric surgery, I'm going to say in treating obesity. Because that's where we're going to actually, I think, in my view, make a huge difference. And I just want to add something. Instead of the dystopian view of Gattaca, is to understand that how we use genetics makes a huge importance, makes a huge difference. I still think that we can use it in the benefit of the patient, not to preclude them from having a surgery, or not to start selecting them to a surgery that they don't want, like it was mentioned in the beginning. So I'm sort of against the dystopian view. Maybe I'm too Pollyanna, but I still think human beings are good human beings.
The borderline between science and science fiction is so thin, so narrow at this time. I mean, it is exciting, but a little scary as well. We have some individuals, some participants whom we haven't heard from. I mean, I don't want to put people on the spot, but for example, Dr. Benzi, what are your thoughts on what you've heard so far?
So actually, what I was thinking was more along the lines of, like, this is really epigenetic modification, and perhaps because we've added so much processed information into like our food supply, preservatives and things like that didn't exist when saber-tooth tigers were running around. What is the impact that that's really going to have on? And in fact, is this kind of disease almost preventable? So if you didn't have those kinds of processed foods that created that kind of hypermethylation all along these sequences, is there any impact of regulating those from like an FDA perspective as well? Because a lot of our patients get immunotherapy, are cancer patients, and that's difficult enough for us to get insurance approval. Even if like medications like Opdivo now, for example, are shown to be benefit in metastatic esophageal cancer, it's still very challenging to get approval, and then for those patients to even get monthly, weekly infusions. So do you think, in retrospect, before this surgery or any medications even started, what kind of impact do you think epigenetic modification has from our food?
Dr. Son?
Wow, that was
very, very thought-provoking.
Yeah, that was. I have to take a moment to just digest, no pun intended, but that that comment and statement. Yeah, I think the 21st century food in itself has changed so much. The epigenetics that you do mention, I'm curious too how that influences the positives and negatives of obesity disease. I don't know, but I think it's now you put it on my radar and something I'll be on the lookout for any future research.
It'll be certainly interesting to follow. And, you know, we know that the offspring of patients who've had, say, gastric bypass tend to not become obese and vice versa. So there's a lot of information to support epigenetics there. Dr. Rosemurgy.
Can you hear me now?
Yes, sir.
Yeah, good. So you run through the genetics of this whole thing, and you find that there's through this genetic analysis, you find out that someone is not going to do well with a restrictive procedure, and rather they need a gastric bypass or some form of a malabsorptive procedure. You discuss it with the patient, and they have their mind set up. They want something other than what you're proposing. For example, let's say the genetic studies suggest that they're going to do well with the sleeve, but they want a gastric bypass. Would you be in a position, if the data was compelling, to say, no, I won't operate on you? Or would you do what they wanted?
So this is one of those clinical dilemmas that we briefly touched on at the top of the talk, meaning, you know, how will it direct matching the patient with a particular operation? And Dr. Son, we're not there yet, are we?
I don't think we're there yet, but
No,
even
genetically we're not, and the basic science is not there yet, but when it is, and this is thereby a hypothetical question, assuming that you have the information that tells you that somebody has a very high likelihood of doing well with a bypass operation, for example, but not, or a malabsorptive procedure, but not doing well with a restrictive procedure, would you then have that dictate the care that you offer? Would you decline to give them the operations that they're not going to do well with?
I would educate the patient on what I know and what data supports what I know, and give them that information.
And they have that information now and they make the wrong choice. What would you do?
Well, I think I played the role as an educator and help them get to what they feel comfortable with, and patient autonomy is ultimately.
You don't think I'm going to let you off the hook by giving me a bunch of verbal
Alex,
answer here. What would you do? The thing about surgery that people don't like is that you have to do it or not do it. And if you're an internist, someone can come back and you can adjust their calcium channel blockers, or you can give them a little more insulin or a little more thyroxine or whatever the case is. But with what it is in surgery, it's black and white. What would you do?
I would say I would do what the patient would want as their operation, knowing that until
she froze.
Yeah.
But, you know,
let me help her on that, Samir. I think what she was trying to say is that she would try to educate the patient the best that she could, give the patient the information. And if there is nothing that will preclude the patient to have what's not the optimal surgery, that she'll proceed with that surgery. But if there is something that will preclude them, not genetically speaking, but surgically speaking, then she would not do the surgery. I think that's what she was trying to say.
One of the things that's fascinating to me about healthcare is that if a woman came to me, because most women get gallbladder operations, or gallbladder operations are more common with women, but if a woman came to me and she wanted a gallbladder out, and for no compelling reason that I know of, I wouldn't do it. None of us would do that. We wouldn't operate on someone who didn't need it. Yet if I went to see a plastic surgeon and I wanted them to implant a doorknob into the middle of my forehead, I'm sure that they would be very willing to do so. Similarly, if I saw a patient with pancreatic cancer and a patient's got liver metastasis, I'm not going to operate on their pancreas because I can't help them. But you're going to take a different tact and say, even though the data is very compelling, you're going to do what they want. Now, the next question then, of course, is that how is this going to impact payers? Aetna's going to say, well, did you do this genetic profiling? And you'll say yes. And what's the genetic profiling promote? And it's gastric bypass. But you want to do a sleeve. Yeah, well, that's what the patient wants.
Yeah,
I
so
think,
if I may, you know, Alex, in our clinics, we face this clinical scenario every day.
Yes.
We have patients coming in. My first question to them is, did you watch the seminar? Second question is, which operation do you prefer? And because they come already set with a set mind, as you know, the mindset rather, that they want the same operation that their family member had or their friend or their, and then based on their diseases, their comorbidities, their anatomy, their past surgical history, I either agree or disagree. And I tell them, sorry, the sleeve that you're asking for is not for you. And we, frankly, I stick to that. And if the patient is adamant, I can always discuss it in a multidisciplinary setting. We can come back. But even before the advent of genetic information to direct us, we already have these clinical scenarios, these dilemmas that we face on a daily basis.
One of the big things that's going to come out of all this is going to be adjusting patients' diets, isn't it? To a high carbohydrate or low carbohydrate. Things like the Atkins diet's going to work very well for somebody, and so on and so forth. That's going to be a major development. How close are we to that? Dr. Son? Your microphone, I don't think your microphone's working.
she back?
Yeah,
Yeah.
I'm not sure.
Yeah, I don't think we have that rich, that refined data yet. Well, we have.
Are people actively working on this? I mean, this is really a great thing. Are they actually working on it?
The only thing I can tell you is that in terms of when you look at research on diet alone and changes in nutrition, what counts most, it seems to be overall the calories that should decrease more than decreasing carbohydrates, decreasing fat, or decreasing this or that component. So
Yeah.
it seems to be that overall, no matter what, people who have a higher preference for a carbohydrate diet, just by doing a low carb diet, they're going to do really great, just because overall they're going to decrease their calories
Sure.
anyways.
Oh, to be 35 years old again and be starting my career. Oh, you have no idea. I'll tell you what happens is one day you look in the mirror and there's an old guy looking back at you and you wonder where all the time went.
Are you wishing you were a bariatric surgeon? Is that what you're saying?
There was a time in my life when I did a lot of this. I did over 1,000
I
of them
know.
and then recruited someone to take my place. They were the happiest patients I had in my clinic.
So true.
Because you took them from a place where they were with a very high morbidity, you operated upon them and you reduced their morbidity. Patients with cancer, pancreatic cancer, esophageal cancer, liver cancers, they feel pretty good. And then what you do is you reduce that and they are encumbered by it in ways that people who had bariatric surgery weren't, because they would go from here up to here. They felt better after their operation. Their attitude was better. Everything was better. And they had some issues and they needed some psychological support maybe, but they did. But they were the happiest patients I had in my office.
So true. We have 5 minutes left, and I'd like to just ask some of the other participants who haven't had a chance. I see my friend Gordon Wisbach here. I don't know if you can if you can participate, but what are your thoughts on the deliberations we've had? Hey, Gordon. There you are. Hi, good to see you.
Got me. Thanks very much. I appreciate it, Samir. Mattar asked me that question, and Yes, I've been listening. Always want to know the latest and greatest with where gene therapy fits in. And clearly it sounds like a lot still needs to be discovered. I enjoyed the
Do you
conversation.
think this is going to be a major benefit for our patients and help us match them to the right operations and help them through the rest of their lives? Or do you think it's going to be used against them?
Yeah, I heard your question about that. Right. Disqualifying patients for it. Right. No, that's a wise consideration, because it's not, you have to hear both sides to it. So I think that's reasonable. I'm not going to pretend to know where you're asking me my opinion. I just want to hear the latest conversation on the topic, but it's not clear that we're going to be based on genes. I think picking the operation, I'd be more concerned about new discoveries, be medication or bioform, in the gut affecting the epidemic.
All right, we are nearly done. Does anybody want to make any comments? Yes, Rohan.
Yeah, in the interest of time, I think we should probably wrap up and thank everyone very much, especially you, Dr. Son and Dr. Mattar, for an excellent moderation of this topic. Thank you all for logging in. We would really love your support of this webinar series, which is actually led by our Advanced GI Fellows. These are the Fellowship Council sponsored Advanced GI Fellows. We have 2 past presidents on this call of the Fellowship Council, so we're very proud of that entity. Please do rally support for this. This will be available online. LK will send you a link for that. And I think our next December meeting is actually our fellow Michael Jujurula talking about esophageal replacement after bariatric surgery. So an interesting topic too, that will be of significant interest, that was stimulated by a case of esophageal cancer that we've had after sleeve gastrectomy. And so trying to figure out how to deal with that. So thank you again, Samara. Thank you, Tiffany. David, thank you for joining us. And we look forward to support from everyone in the future. So please do join. Thank you, everyone.
And thank you, LK and Paige, for your